Okay, welcome to part 2 of the Handbook of Signs and Symptoms, where we speak about each sign and symptom individually and extensively. In the first part, we spoke about the history and physical examination for abdominal distension, and now we'll speak about the medical causes that cause abdominal distension. Remember, this is only about abdominal distension. We'll speak about abdominal masses and other things in other videos. This book goes. Medical causes of abdominal distension. First, I will list the medical cause, all the medical causes mentioned, then I will speak about each one of them individually. So, medical causes of abdominal distension: abdominal cancer, abdominal trauma, cirrhosis, heart failure, irritable bowel syndrome, large bowel obstruction, small bowel obstruction, mesenteric artery occlusion, peritonitis, toxic megacolon, and paralytic Alias. So first we will start with the abdominal cancer. Generalized abdominal distension may occur when the cancer, which is most commonly ovarian, hepatic, or pancreatic, when this cancer produces ascites, which is usually in a patient with a known tumor. When the patient produces ascites, the abdominal distension happens. It's an indication of advanced disease. Shifting dullness and a fluid wave accompany distension. Associated signs and symptoms may include severe abdominal pain, an abdominal mass, anorexia, jaundice, gastrointestinal hemorrhage in the form of hematemesis or melena. Also other associated signs: dyspepsia, weight loss that progress to muscle weakness and atrophy. So that was about the abdominal cancer. Next, abdominal trauma. When brisk internal bleeding accompanies trauma, abdominal distension may be acute and dramatic. Associated signs and symptoms of this life-threatening disorder include abdominal rigidity with guarding, decreased or absent bowel sounds, vomiting, tenderness, and abdominal bruising. This is in case of abdominal trauma. Pain may occur over the trauma site or over the scapula if abdominal bleeding irritates the phrenic nerve. Signs of hypovolemic shock, such as hypotension and rapid thready pulse, appear with significant blood loss. Next comes cirrhosis. In cirrhosis, ascites causes generalized distension and is confirmed by a fluid wave, shifting dullness, and a pedal sign, umbilical eversion, and caput medosa, which is dilated veins around the umbilicus. These are common in case of cirrhosis. The patient may report a feeling of fullness or weight gain. Associated findings include vague abdominal pain, fever, anorexia, nausea, vomiting, constipation or diarrhea, bleeding tendencies, severe pruritus, palmar erythema, spider angiomas, leg edema, and possibly splenomegaly. Hematoemesis, encephalopathy, gynecomastia, or testicular atrophy may also be seen. Jaundice is usually a late sign. Hepatomegaly occurs initially, but the liver may not be palpable if the patient has advanced disease. Next, heart failure. Generalized abdominal distension due to ascites typically accompanies severe cardiovascular impairment and is confirmed by shifting dullness and a fluid wave. Signs and symptoms of heart failure are numerous and depend on the disease stage and degree of cardiovascular impairment. Hallmarks include peripheral edema, jugular vein distension, dyspnea, and tachycardia. Common associated signs and symptoms include hepatomegaly, which may cause right upper quadrant pain. So hepatomegaly, nausea, vomiting, a productive cough, crackles, cool extremities, cyanotic nail beds, nocturia, exercise intolerance, nocturnal wheezing, diastolic hypertension, and cardiomegaly. Okay? Next, irritable bowel syndrome. Irritable bowel syndrome may produce intermittent localized distension, the result of periodic intestinal spasms. Lower abdominal pain or cramping typically accompanies these spasms. The pain is usually relieved by defecation or by passage of intestinal gas and is aggravated by stress. Other possible signs and symptoms include diarrhea that may alternate with constipation or normal bowel function, nausea, dyspepsia, straining and urgency at defecation, a feeling of incomplete evacuation, and small mucus-streaked stools. Next, we have large bowel obstruction. Dramatic abdominal distension is characteristic in this life-threatening disorder. In fact, loops of the large bowel may become visible on the abdomen. Constipation precedes distension and may be the only symptom for days. Associated findings include tympany, high-pitched bowel sounds, and the sudden onset of colicky lower abdominal pain that becomes persistent. Fecal vomiting and diminished peristaltic waves and bowel sounds are late signs of large bowel obstruction. Next, mesenteric artery occlusion, acute mesenteric artery occlusion. In this life-threatening disorder, abdominal distension usually occurs several hours after the sudden onset of severe colicky periumbilical pain accompanied by rapid, even forceful, bowel evacuation. The pain later becomes constant and diffuse. Related signs and symptoms include severe abdominal tenderness with guarding and rigidity, absent bowel sounds, and occasionally a bruit in the right iliac fossa. The patient may also experience vomiting, anorexia, diarrhea, or constipation. Late signs include fever, tachycardia, tachypnea, hypotension, and cool, clammy skin. Abdominal distension or GI bleeding may be the only clue if pain is absent. Next, paralytic Alias. Paralytic Alias, which produces generalized distension with a tympanic percussion note, is accompanied by absent or hypoactive bowel sounds and occasionally mild abdominal pain and vomiting. The patient may be severely constipated or may pass flatus and small liquid stools. Next, peritonitis. Peritonitis is a life-threatening disorder in which abdominal distension may be localized or generalized. Depending on the extent of the inflammation, fluid accumulates within the peritoneal cavity and then within the bowel lumen, causing a fluid wave and shifting dullness. Typically, distension is accompanied by sudden and severe abdominal pain that worsens with movement, rebound tenderness, and abdominal rigidity. The skin over the patient's abdomen may appear taut. Associated signs and symptoms usually include hypoactive or absent bowel sounds, fever, chills, hyperalgesia, nausea, and vomiting. Signs of shock, such as tachycardia and hypotension, appear with significant fluid loss into the abdomen. Next, small bowel obstruction. Abdominal distension is characteristic in small bowel obstruction, which is a life-threatening disorder and is most pronounced during the late obstruction, especially in the distal small bowel. Auscultation reveals hypoactivity or hyperactive bowel sounds, whereas percussion produces a tympanic note. Accompanying signs and symptoms include colicky, periumbilical pain, constipation, nausea, and vomiting. The higher the obstruction, the earlier and more severe the vomiting. Rebound tenderness reflects intestinal strangulation with ischemia. Associated signs and symptoms include drowsiness, malaise, and signs of dehydration, signs of hypovolemic shock. Associated signs and symptoms include drowsiness, malaise, and signs of dehydration. Signs of hypovolemic shock appear with progressive dehydration and plasma loss. Finally, toxic megacolon, acute toxic megacolon. Toxic megacolon is a life-threatening complication of infectious or ulcerative colitis. It produces traumatic abdominal distension that usually develops gradually and is accompanied by a tympanic percussion note, diminished or absent bowel sounds, and mild rebound tenderness. The patient also presents with abdominal pain and tenderness, fever, tachycardia, and dehydration. Okay, this is all about the cases associated with the abdominal distension. And now we have some special considerations about pediatrics and geriatrics. So, pediatric pointers. Because a young child's abdomen is normally rounded, distension may be difficult to observe. Fortunately, a child's abdominal wall is less well developed than an adult, making palpation easier. When percussing the abdomen, remember that a child normally swallows air when eating and crying, resulting in louder than normal tympany. Minimal tympany with abdominal distension may result from fluid accumulation or solid masses. To check for abdominal fluid, test for shifting dullness instead of a fluid wave. In a child, air swallowing and incomplete abdominal muscle development make the fluid wave difficult to interpret. Sometimes a child won't cooperate with a physical examination. Try to gain the child's confidence and consider allowing him to remain in the parent's or caregiver's lap. You can gather clues by observing the child while he's coughing, walking, or even climbing on office furniture. Remove all the child's clothing to avoid missing diagnostic clues. In neonates, ascites usually results from GI or urinary perforation. In older children, it results from heart failure, cirrhosis, or nephrosis. Besides ascites, congenital malformations of the GI tract, such as intersusception and volvulus, may cause abdominal distension. A hernia may cause distension if it produces an intestinal obstruction. In addition, overeating and constipation can cause distension. Finally, geriatric considerations. As people age, fat tends to accumulate in the lower abdomen and near the hips. Even when body weight is stable, this accumulation, together with weakening abdominal muscles, commonly produces a pot belly, which some elderly patients interpret as fluid collection or evidence of a disease. Thank you very much, and that was all about abdominal distension from the Signs and Symptoms Handbook. Thank you very much for watching and listening, and please leave a comment, share, like, and subscribe, and take care of yourself.